And I would just like to introduce Professor Stephen Lord, who's a Senior Principal Research Fellow at Centre Director for Falls, Balance and Injury Research Centre, NEURA. Stephen today is talking about falls prevention research update, effective interventions in the community hospital resident aged care settings. Welcome, Stephen.
All right, thank you very much, Ash. It's a pleasure to be here in Orange. My only regret is I'm not staying for the weekend to really enjoy it. So I'm afraid it's just an up and back trip. So we just get my slides working. And also hello to everybody who's joining us virtually today. While that's doing, just to start off, so what I'm going to do is just to look at a number of different areas in terms of what we know about in terms of preventing falls. Much of what I'm going to talk about initially is in relation to exercise because it's by far the most evaluated effective strategy for fall prevention. Before finishing up with what we call the gold bar research. So just looking at the evidence from all systematic reviews about what we know as the most effective ways to intervene to prevent falls in the three settings: community, hospital and residential aged care. So starting off with exercise, and what I generally start with is systematic reviews. And this one is a few years back, but it's quite comprehensive and it's consistent with Cochrane reviews, which are the gold standard ones. But in this case, it was led by Kathy Sherrington and it involved 99 comparisons. So from 88 different randomized controlled trials and nearly 20,000 participants. So by the time you get to that sort of level of evidence, you can be pretty sure something's going to work or not work. So it's a very, very strong evidence database. Kathy continues this work and it's now well over 100, but the story remains the same as I'm going to present today. So here are the results, and this is how it's presented. And there are so many trials now, you can't see it anymore. Each of those lines represents a study, and each of those horizontal lines with a dot represents sort of the effect size of the study. So any dot that's on the left means that it's protective, and you can see if you go down, most of them are. So you can summarize that in one statistic, and there it is, it's called the relative risk. 0.79, and the confidence interval doesn't go as far as 1. So that means a significant difference. And overall, it's a 21% reduction in falls. So exercise works. So that's all of the studies that have looked at it. If you look at the average effect, exercise reduces falls by over 20%. But because there's such a wealth of evidence, what we went on to do was to try and tease out the components that are really important for fall prevention. Looked at all sorts of factors like home-based versus centre-based, who conducted the exercise and so on. But two key factors emerged as the really critical ones. One is having a balance component. So that's a moderate to high challenging balance component. So that's the key factor. And what that means really is having people on their feet for a start. So it rules out, chair-based exercise and so on. You really need to challenge the person in what they do. It's kind of like task specificity. So movement of the centre of mass, narrowing the base of support, and minimising the use of the upper limbs. So people are challenging their balance. So that's the key factor. And the other one was the dose. And the dose that came out in the last systematic review was 3 hours of prescribed exercise. That doesn't mean everyone actually does the 3 hours, but it's prescribed in the hope that people will get close to the 3 hours. But it's more than just a 1 hour of exercise per day. And we've got the two extremes here. You can see on the left, if you've got a low challenge to balance and a low dose, the fall risk reduction is only 10%, and that's not significant. So that's the worst case. But if you've got a moderate to high challenge and greater than 3, it's right up there at nearly 40%. So that's the clear evidence about what to do. Make sure you're challenging balance. And if you've got a short-term program, try and put in place a home exercise program, etc. So people keep exercising when they leave the program, because it's pretty clear if you stop exercising, you stop getting the benefits. So it is an ongoing process. So what I'm going to do now is just to, in the middle part of my talk, is to look at some of the work we're doing at Neura, where we're trying to go beyond some of the standard exercise programs to look at two extra components. So what we call volitional stepping and also reactive balance training or reactive step training, because these are both key factors in why people fall, particularly in the community. People trip over obstacles, and they do this for two reasons. They fail to see it and negotiate it, or when they do hit it, because they haven't seen it, they can't react in time. Now, these are ways we can incorporate these into our exercise programs, the voluntary one being a little easier at this stage than the reactive one. But first of all, just in terms of volitional step training, what we've done, if I can move on to the picture. All right, so here we've got a fall prevention strategy. I think someone else is talking about fall prevention right through the lifespan, and this would certainly be a good start. But you can see quick, accurate stepping. So particularly the guy on the right, very, very live on his feet. And you'd have to say, if he can do that so quickly and so adaptively, he'd be at low risk of falls. So that's the model that we've taken. So it's Dance Dance Revolution. Can that be adapted to older people? And can that be done in a person's own home, in their own home? So this is a trial that's only came out this year, and we were really lucky enough to have this published in Nature Medicine. So it's had really quite a high impact right around the world. It's been amazing to see the difference if your paper gets published there. So it's been very nice to see it, and I'll just describe what was involved. So as it did involve a step mat, and the step mat was provided to people, and they took them home and they had some instructions about how to do some home-based step exercises. But we did something more interesting too, and this may have been the reason why it was accepted in the Nature Journal. We added an arm where people did exactly the same program, but they did it seated. So the same exercises, but they're sitting at a computer playing on a keyboard. Now, the purpose of these step games is to not only provide a physical challenge, but also a cognitive challenge. So that's why we included the seated one, because it has the cognitive challenge, but without the stepping component. So it was a big one, 750 people. So 3 arms, a control, seated exercise, and a stepping program. And the primary outcome, of course, was fall. So we monitored people up for a full year to see the fall rates. But we also wanted to look at why it worked. So we looked at physical function, neuropsychological function, and we even did some brain scans to see if it's making changes in neuroplasticity. So it was a comprehensive intervention. So in general, what did it involve? You can see the person with the setup there in their home. They do everything with their feet. They turn the games on with their feet by starting with the go button. There's no hands. Everything's done with your feet. So you're playing computer games on your feet. It's called a cognitive motor intervention. And the seated group did exactly the same games. We set the same time limits, but they did everything while seated, and we're just getting, the benefit of the brain training. The games were all sorts of. The aim was to make it as interesting and engaging as possible. So there was games like Step Mania. We had Space Invaders. We had Snake. We had all these games like walking through a Greek village. We had a cockroach stomping game where you had to stomp on the cockroach but avoid the cactus. So all these games, and they involve all of these. The balance ones, obviously stepping and balance, but also these other important factors like inhibition, selective attention, set shifting. So you've got to think on your feet. But the cognitive one is connected to the game. So it's not like counting back by 5s as you do an exercise. It's involved in the game. So you actually have to inhibit a step if it's a cactus, but step on the cockroach if it's a cockroach. So that's the game. And we had all of those. And this was a 1-year program because we wanted to maintain the intensity throughout the year. And we had the 750 people go through. We looked at reassessments at 6 months, and we followed up falls for a year. I'll just cut straight to the chase with the fall results. And what we found is there was a tendency for both the interventions to work. And the funny thing there is, if you just do the brain training, it looks about half the effect of the step training. So the brain training program wasn't significant. It was close. but the step training it reduced falls on average by 26%. So that was a significant reduction in preventing falls. We had one other interesting finding too, that in people who had a history of falls, the brain training also worked for that group. So they might have been a bit frailer, so that cognitive input is also helpful. So it's this combination of, because we know falls are multifactorial, if we can include the cognitive component and the physical component together, it may well be beneficial if they're integrated in what you're training. The next part is reactive training. So the voluntary training is all about being able to avoid an obstacle and quickly, move your feet to do so. But what about if you can't? If you hit the obstacle, you didn't see it, and you have to recover quickly. This is reactive balance training, and I'll report on one of the earlier trials we've done, which looked at training people in terms of slips and trips. And if you get a chance later to talk to Stephen, he's doing his PhD in our later work, and he's really looking at the mechanisms as to why this might work right at the level of the muscle and reflexes. So this is our setup, and it's I'll go through fairly slowly, because this is a lab-based thing at the moment, but it's kind of like the new work we're trying to do. And so a person walks on a walkway, and clearly they're protected. So they're wearing a harness which is connected to an overhead railing. So if they do fall, which is actually an expected event, they're protected in a nice harness system. So they walk along the walkway, they walk on those tiles, and that regulates their step length, because if people think they might be tripped and slipped, they take shorter protective steps. They also walk to a metronome, and that regulates their step rate because they'll slow down. So we get them to walk normally in this sort of situation. And then along that walkway, what might or might not happen is one of the boards would spring up exactly when they would hit it, and it would cause a trip. Or one of the tiles will move with them on low friction bearings, so it'll actually be a slip. And you can't see where it is, it's hidden. And because it's on this wooden walkway, we can move it around. So it could be on the left or the right side, it could be at the beginning, the middle, or the end of the walkway. So you can imagine what it's like if you're standing there, you're walking there, you've got this walkway, you may or may not be tripped. And the best way to do it is to relax if you can, and trust that you can recover. So it's an interesting thing, and it's exposure. And what I'm going to show now is some before and after pictures. And through some of these, you can see quite an interesting effect and some significant falls. So this is a person early on. They hit the walkway and needed the harness to protect their weight. They would have fallen, and there was not much in the way of a protective response at all. So that could have been a fall onto the face. This is later on, same person after training, a trip and a quick up and over reaction. So there was a startle type response, but a recovery, and she kept walking. In terms of slips, again, he really couldn't recover. He got to the end, and again, he had to have the harness for support. Whereas later on, he's a little bit more cautious and slow, but he rides it out and recovers. So what we found from this study is we had 44 people take part, and it was just 3 sessions of this, so quite short. So that's the other distinction. It's not all year. Can you train people up and it'll get lasting effects? We're still to look at this over a year, but what we found from this trial is at the end of the session, these are falls in the laboratory, so not in the real world, but people got a lot better at this. So there was a 49% reduction in trip falls in the lab and a 67% reduction in slip falls. So people can train. You can actually get beneficial effects from it. What we know, this is a lab-based setup, and we're thinking about ways now that we can actually make this accessible in clinic settings and so on. And Yoshio Kubo, who leads this work back at Neura, is devising this program where people do more of a voluntary slip and trip training. So on the left there's a tether, and when that's released, the person has to step up and over an obstacle. Okay. And down on the right-hand side, there's voluntary slip training. So people slip on a low friction Perspex sheet, and they just get bigger and bigger until they need to take a second step. So this is initial work, but this is going to be undertaken hopefully in the rehab setting in hospitals. And this leads to, so far in our initial work, we've had 75 participants, and it has significant effects on walking speed, the size of a step a person can undertake in different directions, and also the speed at which they can undertake a step. So it's beneficial. What it didn't do was stop people tripping on that walkway. So we've still got to work out something that's going to be more effective for that real world perturbation. The last thing I'd like to show before I get to the summary is where we're heading in terms of virtual reality. So this is the latest thing we're doing with people walking in a virtual world on a treadmill. Anyway, it looks like we might got to show it, but if you can imagine you've got these VR glasses on, you're in another world, walking down a walkway and collecting apples as an extra task, and you come across all of these hazards like a slippery walkway, a crack in the pavement, and you need to be able to, oh, here we go, we got it. So this is the situation. And this is the world that you're in, and you feel like you're in there. You're inside wearing these glasses. You can see your feet, and you can see your hands, virtual feet and hands. That's all you see as you walk along. But you're on this walkway, and you'll see the treadmill will translate. So there's a slippery path that you need to negotiate. And that's the perturbation. So that's a rapid, abrupt change in the treadmill walkway, and it feels like a trip. It moves the other way, and it feels like a slip as well. And here's the person in the real virtual world tripping over something that's not there. So what we've found from this is people like it. They don't want to come out. It's just a very nice, so it's not, the trip and slip walkway is scary, whereas this is not. When you're in the real world, you are in this enjoyable, you look around, you just feel you're there. It had some definite benefits in terms of fewer slip and trip obstacle collisions, but you needed the treadmill to actually do that translation. If it didn't do that and you were just told to walk over these obstacles, there's no consequence. So you could trip on the slippery surface, and if you didn't get the perturbation, it didn't matter. But if the treadmill moves, you learn. So it's a combination of putting in place the VR with actually something that has a consequence. I'm going to go very fast because I think I've 1 minute. Is that all I have? 2 minutes, okay. So basically the last part is really the quick summary on what works. And all of this information is going to go into the new fall prevention guidelines that are going to come out this year. And all of it is based on really large bodies of evidence now from systematic reviews, Cochrane reviews, and reviews that we've done ourselves to make sure we're really up to date. And we use this level of evidence, so 1, 2, and 3 gold bars. If there's 3 gold bar evidence, it's really based on extensive systematic review evidence, and down to 1 gold bar if there's just been a single study. But anything that gets a bar is worth pursuing. So in the community, there's a range of different programs shown to work. The first one is what I talked about right at the beginning, high-level balance training, but also voluntary and reactive step training. So that's the exercise side of it. Occupational therapy, particularly for people who are at high risk of falls. It's more than just the provision of a few safety rails. It's really working with the older person in terms of how they undertake transfers, how they live in their own world. So a really ecological approach. Cataract surgery to both eyes. It's now been shown to be beneficial. If you do it to the second eye, you get back depth perception, so people can see obstacles. Restricting multifocals when people are outside. It's a study that we did a number of years back, but it's also reflected in other experimental studies. They blur the bottom of the visual field, and that's exactly where the obstacles are and increases the risk of trips and slips. So a single pair of spectacles that are for distance vision helps reduce falls. Pharmacist-led education and GP medication reviews. I think we're going to hear more about that today, and that's another crucial factor. And podiatry interventions for all aspects of the feet. This is for people with foot pain, but it's more than you think. So in surveys, that's as much as 1 in 3 older people. So something definitely to look at. In the community, a few more things. It's more specific, but pacemakers for a particular type of condition for prevent syncope. Vitamin D, provided you don't give big doses. So monthly and yearly doses have proved to be harmful, but lower doses beneficial. And then, of course, multi-component, put in a number of evidence-based things together in a package, particularly for those at high risk of falls, and that's also effective. I think we're going to share these slides anyway, so people will be able to see them later on if you can't keep up. Hospital, not nearly as much, all on one slide. Education seems to be the key. Working together, and working with the older person in hospital and their carers and staff, that's been the key factors by far. And then multifactorial interventions based on an assessment is important. It's not so much calculating the score, but as Ash mentioned, really look at the issues, doing the assessment and working at the issues. And then the specific one about people who've suffered a hip fracture, really, taking place the orthogeriatric approach to fall prevention in that group. And then finally, residential aged care, multifactorial programs, vitamin D supplementation again, excluding the big doses. A lovely study undertaken in Melbourne just last year that showed if you provide better nutrition to meet calcium and protein, you could reduce the risk of falls. So just a simple, well, harder to do than you think, but changing the diet to improve those things worked. Tailored exercises works, balance and strength training, and then interventions to promote bone health, either with medications and hip protectors, if it can be done when you've got everything needing to work together, because the biggest problems with that relate to adherence and the practicality of it all. And I can imagine a number of people have tried it and found it too hard, but they do work if it can be done. So I'm going to finish there, and thank you very much.